Good morning, everyone, and welcome to Immersify's first virtual event of 2021. I'm Maria, part of Immersify Education, and we are delighted to have you all joining us today. We would like to give a very special welcome to our community members and our guest speakers. Thank you so much for taking the time to create these awesome presentations, for sharing your experience and your knowledge with us. Also, we want to thank Septodon UK for sponsoring today's event. Since its foundation in 1932, Septodon has always been at the forefront of pharmaceutical dentistry, developing, manufacturing, and distributing a wide range of high-quality dental products, including the Ultra Safety Plus twist. If you want to know more about what they're doing and how we are collaborating with Septodon, please go to our Instagram page at Immersify_ed. You'll find a highlight with some Septodon information, but also some posts that we have been creating throughout the last month. Additionally, throughout the event, you might have some questions. So if you please want to go to Instagram again, our stories, we've just updated a story where you can drop any question, and we will make sure to gather all of them together at the end of the event and pass them on to our awesome speakers. And hopefully we will be able to get back to you very soon. Just to briefly mention our agenda for today, our first speaker is Dr. Barry Oulton. He is a lecturer for Septodon UK, and he will begin our event by covering the topic of pain management and how to create the perfect patient experience every time. Following on, we will have Aster Vas, one of our international ambassadors, and she will be covering what it's like to study dentistry in India, and she will be sharing a little bit about her overall experience. Later on, we will have Maya Samuel. She's a dental hygienist and therapist, and she will be covering the topic of periodontal disease. Moving from the sort of academic side of the event, we will have Leigh. He will be talking about what his experience was qualifying during a global pandemic. And last but not least, we'll have Dr. Mahrukh Khwaja. She is the CEO of Mind Ninja, and she will take some time to talk about the importance of mind fitness, student resilience, and well-being. We thought that this would be like a very appropriate way to finish our event, because we know that you might be going under a lot of stress right now, sitting your exams, and we just want to share a few tricks to overcome these all situations. So yeah, that's the agenda for today. So without further ado, I would like to introduce Dr. Barry Oulton, our first speaker of the day. For those who don't know Dr. Barry, he is the founder of the Confident Dentist Academy. And this academy was created to help dental professionals learn effective communication skills so they can have more impact and have a bigger make a bigger difference, both professionally and personally. As I mentioned before, Dr. Barry is also a lecturer for Septodon, both here in the UK and in South Africa. And overall, he's a highly experienced dentist, lecturer, vocational trainer, and a businessman. So I think that there is no better way to start our event than with Dr. Barry's presentation. His presentation is called Just a Little Prick, How to Create the Perfect Patient Experience Every Time. I hope you guys really enjoyed the presentation, and I'll see you in a bit.
Well, hello. I'm Dr. Barry Oulton, and welcome to Just a Little Prick. Now, that's not a reference to the person that's talking right now. That's really about how we can create the perfect patient experience every single time. And it's based upon my comfortable dental injection technique in association with Septodon. And it also includes the language of influence. Now, I've only got 15 minutes with you, and I would love to be able to spend more time. That being said, I'm going to give you some really great nuggets that you can take away and implement literally tomorrow to make your injection technique better. And then I would encourage you to go and do the whole training. It's only an hour and it's available online, but I'll give you the reference for that later on. So it is called the Comfortable Dental Injection Technique. And it's almost like you have a magic wand. It's really about customer service. You know, when you are a clinical dentist, the bottom line is that your income is truly dependent on having happy patients. It's about developing those relationships, but also having the recommendations and the confidence in your patients that they will accept higher value treatment from you, and, you know, cosmetic treatments and maybe things that they are wanting rather than needing. So there are a number of studies done into why patients do and don't go to the dentist. I'm going to give you the top 10 reasons why patients reported in this study in 2010 by Dr. Joe Bulger in Canada. And he discovered that the top 10 reasons why patients don't go to the dentist are these here. It's the invasiveness, anxiety, a sense of dread, the needle they're worried about, poor service, sounds and smells, bad memories, the pain, the costs, the lectures, and the dreaded drill. So as you look down those lists, tell me what you think the top 2 are. Now, most people would say that in the top 2 would be costs. Costs are important, but they're not the most important. Let's look at what the top 10 are in order. At the bottom of this is bad memories. Then we have poor service. They want to be looked after, don't we all? Understandably. They don't want to be lectured to. They don't want to be felt that they're being patronised or told off for what they haven't done or what they are doing. Costs are only number 7. Then we have sounds and smells, the invasiveness, the drill itself, the anxiety, and then the top 2 reasons why patients don't go to the dentist. Number 2, the fear of the pain, and the most important one is the needle. Now, as you look at that list of 10, notice that 7 out of the 10 are related to pain management. And they're either based upon their own past experience or the experience of somebody else's opinion. So it's super important that we're aware of this, because these are the 2 things that I believe, with great technique and great materials, we can eradicate. Now, the top 10 reasons why people keep going back. I don't have time to run through the whole thing. Interestingly, though, the top 2 reasons why patients keep going back to you and me and their dentist is number 2, the dentist does not hurt. And number 1, it's a painless injection. So how important is it to the patient that we are providing comfortable dentistry? Well, clearly, the top 2 reasons why they don't go and why they keep going back are the same 2. So I want to ask you, whatever stage you are in your career, how good are you at this? What's your customer satisfaction rate on your quality of your injection, and then ultimately the comfort of your dentistry? That's why I developed the CDIT, the Comfortable Dental Injection Technique. Let me show you an example.
Let me sit you up, Trouble. Right. Do you want to have a look? You can swallow for a second. Right, listen. How old are you?
9.
9. We have lots of children that come here that are nervous and worried about having injections. How was your injection?
Fine.
Did you know you had an injection?
No.
So do you know that I've just given you an injection up here?
No.
So was it comfortable? Did you feel it?
No.
No. So if you know now that you need an injection from me, would you be happy with that because I'm good at it? Yes. So next time if you come for an injection for a filling, would you be more relaxed and happy? Yes, good. Thank you. Do you want to have a rinse out? For a second.
Yeah. Did you just do the things?
Go on, did I just do what things?
Did you just do the injections?
Why? How was it? How was it?
Absolutely fine.
Good.
Yeah.
Good. That's why I'm recording you, right? Because I've got a series of lectures to do around the country, teaching dentists what I just did. But most people think they can do injections, whereas most patients are worried about it. So tell me, if you don't mind, how were you before last visit?
I literally I couldn't sleep the night before. I cried the whole car journey, and then didn't even realise you did it, did I?
Good. And so how was it today?
Absolutely fine.
So you've just had 1, 2, 3, 4, 5 injections. All good?
Yeah.
Good. So today you came on your own?
Yeah.
Much more relaxed? Happy to have the treatment?
Yeah, I'm ready.
So would you recommend that technique?
100%. 100%.
Good.
Yeah.
Thanks for that.
Ah, she makes me smile. So, given that this is normally an hour long, I'm going to cut things short. Let's look very briefly at the physiology of pain. And thank you very much to Andrew Mason, who is Senior Clinical Lecturer at the University of Dundee, for his drawings. I want to remind you of the gate theory of pain. Let's look at the classification of nerve fibres just for 1 second. We have C fibres that transmit nociception, that's pain. We have A delta fibres, which are myelinated, and they transmit nociception as well. But then we have A beta and we have A alpha fibres. They're much thicker, they're much more highly myelinated, and they're much faster. If you look at the speed relative, there's a walking pace for the C fibre, but then when you look at mechanoreceptors and motor, they're so much quicker. Now, the transmission of pain runs through the periphery. If you have a noxious stimulus on the periphery, it travels through into 2 synapses. The first is in the brainstem and the second is in the thalamus. Then it goes up to the cerebral cortex and we notice pain. It was Melzack and Wall, if you remember this, that came up with the gate theory of pain in 1965, and we're still using that theory of pain right now. In essence, what Melzack and Wall postulated is that a noxious stimulus travels through A delta and C nociceptors. It goes through to the synapse and then continues through second order neurons. Now remember, C fibres and A delta fibres, they transmit their nerve impulses very slowly. At that synapse, we have the opportunity to interrupt, because what it says is that only one of those signals can get through the gate. Imagine that you have a 3-year-old child, he's playing in the park, he falls over and he bangs his knee. What do you do to that knee? You rub it. Well, that's the gate theory of pain. When you're rubbing the knee, the impulse for the mechanoreceptor travels so much faster than the nociceptive impulse that the sensation of touch goes through the gate, closes the gate, and we stop feeling the sensation of pain. This we can use to our advantage. And many things have been tried in dentistry, like this thing was called the vibrojet. The vibrojet was a great idea. However, the idea was it would vibrate the tip of the needle to stimulate the mechanoreceptors and therefore close the gate to pain. But it was heavy, it was noisy, patients didn't like it. I purchased a really expensive mechanoreceptor gate theory of pain inducer. Would you like to see it? I have thousands of these. It is simply this. You see, I will use a Q-tip with my topical anesthetic. After I've left that for a minute, prior to my injection, I will wiggle my Q-tip, therefore evoking the gate theory of pain. And what that does is it switches off their sensation of pain, because the sensation of me rubbing means that it closes the gate. Next thing is, we have this thing called top-down modification. Top-down modification can either increase the thoughts of the sensation of pain or decrease it. My example for this is that I will ask the patient whether they can wiggle their toes. Just as I'm about to engage the needle, I say, look, can you wiggle your big toes without wiggling your little toes? Now, I don't mind what the answer is. What I'm doing is I'm distracting them. I'm taking their attention away from what I'm doing down to their feet. And invariably they go, yes or no. But by the time they've done that, I've given my first injection. Again, so much more I could share with you. Top-down modification, distraction. Ask them a question, because questions are one of the most powerful language patterns to the subconscious mind. A question has to be contemplated in order to be answered, whereas a statement can be rejected or accepted. So if I say, can you wiggle your toes? boom. If I say, can you wiggle your big toe without your little toe? They have to think about it. That means they're distracted. So I would love you to be world class at your communication. It is communication that has enabled my injection technique to become so popular. I also want you to make sure that you are using the very best in materials to ensure that, number one, it is the most comfortable injection they've ever had, to the point that they don't even know they've had it. Just like Poppy, just like Amy. That's like every single patient I treat every single day. They are blown away because they have no idea they've had the injection. So when it comes to materials, let's have a little look at the injection technique. Now, there's a QR code there if you want to go and get the full training. But this is my recommendation. Number one, always use a topical anesthetic. It is an essential step in this process. You could argue that the topical anesthetic only gives a very surface level anesthesia, but it does two things. Firstly, the surface level for my first injection. Secondly, top-down modification, because I will say to my patient, I'm going to rub in the magic gel. They go, the magic gel? I say, yeah, the magic gel. It's a numbing cream. It's amazing. Oh, you're not going to do an injection? Well, I'm just going to use the magic gel silently right now. It's not used by everybody. By all accounts, only 40% of patients are afforded the benefit of having a topical anesthetic. So if you're not using one, use it, because it will affect them top down, and also it anesthetizes just the surface area, which is what we want for the technique to work. Secondly, you have to use an incredibly good needle. Not all needles are the same. If you look at these pictures, if you're not using something like Septajet, or you're not using anything from, quite honestly, from Septodont, then you could be getting needles that are poorly manufactured. And if you look at that row, imagine the tissue damage that those needles are doing. So for me, all I am using literally all the time is the Ultra Safety Plus. And more recently, the Ultra Safety Plus Twist, which is locked onto the handle, so it's much less likely to cause any issues for you. So, firstly, great needle. Use a great needle which is sharp and cuts through butter. Secondly, anesthesia. I only use Articaine. It's the only thing that I have in my drawer, because I can use that on anybody. There is no contraindication to using Articaine on anybody. And the reason I do that is because I don't do these. If I do an ID block, which, by the way, the last time I did one was probably 6 years ago, I know that my ID block is not completely undetectable. I may be able to make it comfortable, but the patient definitely knows that they're having an injection. Whereas with my technique, if I'm giving an infiltration, my patient doesn't have a clue that they're having an injection. So it's very important that I'm using the best local anesthesia I can. And so for me, I will give buccal and lingual infiltrations using Articaine only. Next thing, bevel direction. What were you taught about bevel direction? Well, for me, when I was an undergraduate, I was taught that the bevel direction was really about its approach to the bone. And this picture here demonstrated that this is incorrect orientation. Why? Because as you approach the bone, if you're not parallel to it, there's a risk that you can damage the tip of the needle. Let me refer back to the way that I was taught to do an inferior alveolar block. And that was to insert the needle, to touch bone, and then withdraw. Could you imagine that when you place the needle in for an ID block and you touch bone, that something like this might happen? Now, the middle picture is probably less of a risk and less of a damage to the nerve. But look at the bottom picture. Imagine that the nerve is underneath the needle, and as you withdraw that, that is likely to cause bruising and damage. And so the whole idea of bevel direction originally was to have the bevel parallel to the bone. So I want you to think about this. When you use the Ultra Safety Plus, there's a little Christmas tree on there. Can you see that? That is your bevel indicator. Now, most people don't realize this, but rather than looking at the tip of the needle and trying to find the bevel, all you need to do is locate that little mark. That little mark tells us exactly where the bevel is. Let's look at a previous technique. You apply topical anesthesia. You might get just a surface amount of anesthesia to the soft tissue, and then you approach with your bevel parallel to the bone, which means it's likely to be perpendicular to the soft tissue surface. You engage the needle. This initially is completely comfortable because of the topical anesthetic. You approach a little further and you see a wince in the patient's eye. It's not agony, but it's a little bit uncomfortable. And this is where you go, oh, you're just going to feel a little prick. You can't administer the local here because you're not deep enough into the tissue. So you progress further forward, the pain increases. You go even further, the pain increases again. And at this point, you know your patient's uncomfortable. So what do? You release the local anesthetic. Have you ever had a situation where you've seen the local wash over the mucosal surface? That's the point you go, oh, I'm terribly sorry. Doesn't taste very nice. Well, that's because the local is not going into the tissue, it's going over the tissue. So what do? You have to progress it even further. That increases the pain. And it's only here and now, with deeper penetration, can you administer your local anesthetic. Most dentists then go, I'm going to give it really quickly, which can damage the tissues. And whether your patient is 6 or 60 in their head, they're like this little beauty. They're a little baby being hurt. So what should we do? Number 1, notice where that bevel is. You've used your topical anesthetic. You're invoking the gate theory with your little Q-tip. And all you're going to do is you're going to have your bevel parallel to the mucosal surface. You're going to skim just under the surface of the mucosa. And at this point, you're going to administer 5 or 6 drops. That's it. You then withdraw the needle and you say to your patient, how was your injection? Patient goes, what? What injection? You go, thank you very much. You take a bow. You take the lauding. You say, now you know that an injection from me is completely comfortable. What I'm going to do is exactly the same thing. And the patient goes, fine by me. I didn't even know. That was amazing. Now you orientate your bevel for the bone. Now you can engage because that initial area is anesthetized. You progress very slowly and you deliver your local anesthesia a mil a minute. If you get an opportunity tomorrow or the next day, take a syringe. Note that it's a 2.2 mil cartridge. Time a minute and extrude a mil of it, and you'll see how slowly it is. You do not want to be blasting it and tearing the tissue. You want to allow it to infiltrate very slowly. And this is the smiley face you get after doing that. So I've tried to condense so much into that. What I want to do is run through the basic technique, and then I'm going to show you a video, which is available online. You can grab it whenever you want to. And I genuinely believe that if we can get every undergraduate to do this, we will change the face of dentistry over the next couple of generations, because we will remove the 2 things that people fear from the dentist. They fear the needle and they fear the pain. You give a completely comfortable injection technique, they do not fear a needle. You use amazing anesthesia like Articaine and use great needles like the Ultra Safety Plus, and you will do dentistry that is completely comfortable. Right, basic technique. You need a relaxed patient. That comes with your language skills. I can share that with you on another webinar. You want to use great language and supportive language. You want to be telling them, everything I do for you is going to be completely comfortable. I'm going to look after you. And by the way, you're in charge. If you're not completely comfortable, give me a wave, stop me, and I'll make sure I make you comfortable. Topical anesthetic. Leave it on for a minute. Then you're going to use a great local anesthetic. For me, it's only Articaine. Like I said, no IDBs for over 6 years. Consider your bevel direction. My nurse will hand me my syringe based on whether I'm giving an upper or a lower infiltration. You're going to evoke the gate theory. You're going to rub your Q-tip, your cotton bud. That's going to stimulate the area for mechanoreception. You're just going to penetrate the surface and deliver slowly just 5 or 6 drops. You're going to take the needle out and say, how was that injection? And they go, what? You take a bow. Thank you very much. Oh, and by the way, Mr. or Mrs. Patient, can you recommend your friends? Tell them how good I am. Oh my God, Barry, absolutely I will. Good. Then you advance the needle slowly, delivering 1 mil a minute to your desired area for full, complete anesthesia. Articaine takes effect immediately. It takes like 3 minutes to go through the bone because of its lipid solubility. It's a phenomenal anesthetic. Let me show you a video.
Great stuff. Okay, so this topical gel that I'm rubbing in just makes the gum feel completely comfortable. Good stuff. Okay. Thank you. So you're just going to feel me press just a little bit on the gum, and then you're going to feel me wiggle slightly. Good. I'm just going to sit here for about just 5 or 6 seconds. Good. Well done. Excellent. And relax. How was that?
Literally, that's the first injection I've had that I haven't felt. No, I promise.
Brilliant.
Yeah, that's great.
Thank you. Okay, so what I've done, just to let you know, we use that bubblegum topical, which numbs the gum. I've then given the injection. I've given a small amount, and what that's doing now, you'll start to feel this begin to get more numb and more numb as time goes on. And then I'm going to just go back in now, and you should feel literally nothing but me touching. Same again, because I'm going to lightly wiggle. Excellent. And that's it. So now I sit here for about 30 seconds, okay? And we'll just very, very slowly putting the local anaesthetic in. Good, well done. Excellent. And relax. You okay?
Good.
Good stuff. Thank you.
So now I'm going to play that video again, but I'm going to annotate it so that you can pick up on the things that I'm doing and you can mirror that and do it your own way. And I promise you, the more you practice this, the better you'll get and you will wow patients. Here we go.
Great stuff. Okay, so this topical gel that I'm rubbing in just makes the gum feel completely comfortable. Good stuff. Okay. Thank you. So you're just going to feel me press just a little bit on the gum, and then you're going to feel me wiggle slightly. Good. I'm just going to sit here for about just 5 or 6 seconds. Good, well done. Excellent. And relax. How was that?
Literally, that's the first injection I've had that I haven't felt. No, I promise.
Brilliant.
Yeah, that's great.
Thank you. Okay, so what I've done, just to let you know, we use that bubblegum topical, which numbs the gum. I've then given the injection. I've given a small amount, and what that's doing now, you'll start to feel this begin to get more numb and more numb as time goes on. And then I'm going to just go back in now, and you should feel literally nothing but me touching. Same again, because I'm going to lightly wiggle. Excellent. And that's it. So now I sit here for about 30 seconds, okay? And we'll just very, very slowly putting the local anaesthetic in. Good, well done. Excellent. And relax.
So, thank you so much for having me. Thank you to Immersify, and thank you for watching this short presentation. If you would like to know more and you'd like to do the full program, then it is available with the QR code over there. Also, visit me. I do a sales and communication training course called Influencing Smiles, and there's a lot of content on my website. So please go and visit theconfidentdentist.com. I'm Dr. Barry Oulton. Thank you so much for joining me. I really appreciate your time. Take care and bye for now.
Thank you so much, Dr. Barry, for the insightful advice. I hope you all learned a bit more about how to combine careful language, good technique, high quality products like Septodontal Ultra Safety Plus Twist, and how all that combined can help in delivering effective pain management and relief of dental anxiety. And also, guys, if you have the opportunity, please go and get the full training. I guarantee that you won't regret it. Now, moving to our next speaker, we have Aster Vas. She is a four-year dental surgery student from the AJ Institute of Dental Sciences in India. Aster describes herself as a person who exhausts confidence, finds inner strength, reaches goals, and smiles genuinely. And I think you will be able to see this in her presentation. Today, Aster will be discussing her dental journey in India and sort of highlighting the difference between the learning processes there and here in the UK. Before we move into her presentation, just a quick thank you to our friends from Medicrew in India and to all the dental students who are watching now from this beautiful country. Please go and give them a follow on Instagram. They are on RC Medicrew. You won't really regret it. They have really awesome content, really good talks. So go and give them a follow. So I don't want to take much more time from you guys. So I'll leave you with Aster and her presentation on how it is dental school like in India. Hope you guys enjoy.
Hi everyone. For those of you who don't know me, I am Aster Vas, International Ambassador for Immersify Education from India. I'm currently in my 4th year of Bachelor in Dental Surgery. So today, I want to share a very special story with you guys. It's about how is dental school like in India. To get a grip on this story, I feel like I should start a little bit by telling about myself and my struggles. So let's get started. I am a left-handed person in a right-handed world and ambidextrous while practicing dentistry. I've always been a target-oriented, will-to-learn and expressive person. I love playing basketball, dancing, connecting with people and sharing my views on oral health through social media. I have recently published an original research article and a recent pageant winner. At the age of 6, I kind of decided that I wanted to pursue dentistry as my career. As I was growing up, I felt that I'm inheriting medical and technical aspects from my parents and the kind of responsibilities they have. My love for white coats was so deep that I made a personal first aid kit and carried it everywhere I went. I realized that this is a profession where skill and creativity come together, from reconstructing a broken tooth or enhancing the facial form through Botox. I wanted to do something that was specialized enough to where I'm focused and an expert in a specific area, but not to a point where I'm limited to serve the population. So I took science in my pre-university with the subjects physics, chemistry, biology, mathematics. Also, I was keen on learning a little bit of French. Once you finish your pre-university, you apply for an all-India exam in order to pursue your undergrad in a medical or a dental university called the National Eligibility Cum Entrance Test. My results showed that I was qualified to apply to the dental colleges in India. This period was kind of stressful. There is a whole lot of process that goes online once you apply to a college. Later, I got accepted by all the dental colleges that I applied for, and based on my research of expenses and everything, I chose to pursue my undergrad in AJ Institute of Dental Sciences. Finally, the journey begins. In the first year, you are one among the 100 A-type students in your class, and you have to ace it until you make it. The first 3 years, we have a lot of subjects in common with those pursuing medicine. We have subjects like anatomy, physiology, biochemistry, and dental subjects. I think it's quite similar to other dental schools. And first year is when you have a lot of time with your friends and have fun. Most often we would spend some time at the cafe or at the mall. Anatomy labs were one of my best memories. Spending few hours learning with the cadavers was very interesting. We would also get to experience days where some of our batchmates would faint during the lab hours. And the experience we had with the formalin from the cadavers was breathtaking. During my physiology practical labs, we had to prick ourselves with the lancet and estimate our RBC blood count and few other tests. I used to be very nervous and was unable to prick myself at once and collect sufficient blood to perform the test. I would go back home really upset about not being able to perform my best. Also, tooth carving using wax blocks was a part of the dental lab hours in the first year. Second year is the most challenging year. We have subjects like pathology, microbiology, pharmacology, and at the same time oral histology, dental materials, prosthodontics, etc. It's a vast portion of topics and you really have to sit down and study in order to clear exams. I used to find it really hard to memorize and remember the drugs in pharmac. So I prepared my own notes and flashcards for each drug and compiled them together. That really helped me to revise during my exams. During the pharmac labs, we had fun learning how to make toothpaste with basic ingredients, performing gram staining tests. During the prosthodontic labs, we learned how to make complete dentures, and as a part of the course, we had to prepare dentures and teeth arrangements 12 times. It also reminds me of the rural camp we had at a place called Gurupur. My colleagues and I had been to an orphanage where the kids were diagnosed with HIV. We got to interact with the children and present a few talks and games regarding the oral hygiene. Some of the greatest challenges is the workload. You really have to balance your time wisely and manage it properly. In our third year, we start off with the clinical exposure. We get posted daily to the dental surgery and dental medicine departments, which is at the hospital, where we take up case histories on patients and try to diagnose the problem, whether it is a respiratory or a cardiovascular condition or a GI condition. We get to perform general examinations like inspect, palpate, percuss, and auscultate. It's really interesting how you understand the purpose of other medical conditions playing an important role in dentistry in order to provide a better treatment plan for your patients. We also start with the dental core specialty subjects. During the clinical hours, we used to get patients who would walk into the department, but there were times when there weren't any patients. And at that time, I would search for my personal patients. I would try to get my friends or people who required a general hygiene checkup. We would perform preventive or prophylactic procedures, some like topical fluid applications, spit fissure sealants, etc. One of my favorite departments is the oral maxillofacial, where as dental students, we get to learn how to administer LA and perform extractions. There are a few interesting cases that you get to watch and chances of shadowing at the operation theaters and watching the whole procedure being done by the surgeons is an eye-opener. In this year, before my state got into the lockdown, I experienced my first extraction case. I was nervous and at the same time excited. My patient was a 60-year-old female and I had to extract her lower 4 posterior root stumps. I guess my favorite part was where you have to elevate the periosteum with the periosteal elevator in order to get proper access and grip on the tooth. With the help of assistance from my staff, I was able to pull off the extraction smoothly. My patient had to get her upper anterior root stumps removed, and as much as I was excited to do the extraction, I had to recall the patient another time. Taking her age and health in consideration, it was best to give the patient some time to get used to the procedure and let the posteriors heal. I also enjoy the prosthodontic department where we get to work on patients and fabricate removable prostheses, complete dentures or FPDs. learning from them and also seeing them learn from me, imparting everything that I've learned as I explain to them, teach them, and treat them. One such experience is when I had a patient for complete denture, and my patient didn't make it to the appointment several times. And it almost took me 3 weeks to realize that this patient is just making fake promises and isn't going to make it to the treatment on time. That's one of the experiences I guess most of us as dental students can relate to. Patient not showing up at all. In the conservative and endodontic specialty, we get to treat caries and make cavity preparations on patients. We are taught how to perform root canal treatments, composite restorations, rubber dam isolations, etc. Similar experiences learning different techniques on how to do all ceramic crown prep or taking radiographs, making appliances for pediatric patients. Definitely how to do all the different procedures that will enhance me and give me the tools that I need in order to be a great dentist in the future. I'm grateful to be able to balance and feel confident in myself, imparting everything that I've learned so far. During the dental school, I used to attend a lot of conferences. I started to work on my research, attend workshops, present papers and posters on different aspects of dentistry. One such memorable experience was when my colleagues and I won the Oral Awareness Cancer Awareness Competition held at our university, and as a part of outreaching the general public in the city, we performed a street play at the State Road Transport Corporation, chanting slogans and performing an act on the local language spoken by the people. We got to be a part of many such outreach programs held by our university. You also get some time to focus on cultural or sport activities and conduct events once you become a member of the student council in your university. The best part about dentistry is that you can make time for yourself and other activities and at the same time manage to finish your lab work between lecture breaks. There have been days where we take our instruments home and try to finish some of our work past clinical hours. The ratio between the volume and time is something you learn how to balance and the amount of material that you can cover in a day. After the 4th year, we get to work in our college for 1 year as an internship program before we graduate as dentists. I must say that the COVID-19 pandemic has had a huge impact on the dental industry from the initial lockdown in March 2020 to the present day, nearly 1 year later. In fact, it is likely to see fewer people as patients to be visiting dental practices for elective treatments. Despite the disadvantages, surveys showed that the dentists have learned to adapt and succeed. Continuing to get back after a complete lockdown and being diligent on the protocols prepared us for the second wave. The online classes has kept us engaged with our subjects and also allowed us to have the time with our family. Often there are continuing dental education programs which help us, the students, to remain innovative and imaginative in this unprecedented period. During the last year of lockdown, I came up with the idea of collaborating with other dental students and forming a dental student society. We started to host extra revision sessions to help consolidate and embed year 1 to 4 learning. This platform was an exciting opportunity for all dental students to get involved with and volunteer to host these sessions with their choice of subjects, developing teaching skills, and at the same time brush up on certain topics. I strongly believe that in the idea that alone we can do so little, together we can do so much. I'm at the end of my 4th year, and at this point I have a couple of mixed feelings. I do feel exhausted and at times, but also the excitement kicks in when you think about the fact that it's almost over. For me, the excitement of getting to interact with patients on clinic is by far the highlight of every day of every week. The need to have a higher level of discipline, of focus, and really taking time to understand my priorities is best put and fulfilled in the field of dentistry. I would like to conclude by saying that dentistry is stressful at times, and we often forget how to take care of ourselves and find peace within in order to perform better. My advice is that take life day by day and be grateful for the little things. Don't get caught up in what you can't control. Accept it and make the best out of it. In times like these, use this moment to develop new skills. Maybe learn to dance, try mandala art, or talk to your old friends or host virtual movie nights with them. Something else that makes you feel better and connected. I hope everyone is safe, vaccinated, and that the pandemic ends soon. Thank you for listening.
Thank you, Aster, for taking the time to share your dental journey with us. Please give her a follow Dental Student Society as well. And overall, I just wanted to quickly thank you guys for tuning in. It's great to see you all on YouTube and all of our other platforms. If you don't want to miss any of the following events, please give us a follow on YouTube. Continuing with our agenda for today, we are super excited to introduce Maya Samuel, who is a dual qualified dental hygienist and therapist. She graduated from the University of Leeds back in 2018. And as you will be able to see, she has a passion for dental disease. And that's why her presentation will give you all you need to know about this fascinating subject. Maya, in general, works really hard to equip all future dentists, hygiene and therapy students, dental nurses, and technicians with all the knowledge there is to have on how to prevent gum disease, the leading cause of tooth loss and tooth decay. You can follow Maya on her Instagram at The Hygiene. She shares really interesting dental-related videos and posts. She has over 3,000 followers, so it's definitely worth following her. So I really hope you all enjoy her presentation. And here is Maya and periodontal disease, everything you need to know.
So, hi everyone, my name is Maya and I'm here to tell you as much as I can about periodontal disease. So let's get cracking. Periodontal disease. Periodontitis is derived from the Latin word peri, meaning surrounding, odont, meaning tooth, and itis, meaning inflammation. So by definition, gum and bone disease. So it is always initiated by gingivitis, and it is considered to be the later stage of gum disease, and it's a chronic inflammatory infection triggered by the prolonged exposure of bacterial presence at the gingival margin, which will eventually result in the destruction of the underlying supporting tissues. So if it's left untreated, it would eventually result in tooth loss, and approximately 70% of all tooth loss amongst adults is as a result of perio. So a lot of it could have been avoided. So how does it occur? It is from, as I mentioned earlier, the prolonged exposure of bacteria at the gingival margin, which will eventually result in the migration of that bacteria underneath the gum line down the apices of the tooth and result in something called a pocket. So this pocket is basically a breeding ground for bacteria to multiply and release further toxins, and it will result in the destruction of periodontal ligaments and fibres. And as the pocket deepens, bone loss will incur, and as more bone loss incurs, the tooth will eventually become mobile and eventually it will be lost altogether. So just to give you a visual of what a pocket looks like, this is on the left-hand side a healthy tooth or the healthy gum. So you've got a nice healthy attachment between the tooth and the gum and a good bone level. However, on the right-hand side, you can see that is a BPE probe, which is used to screen gums at the beginning of every hygiene visit and every checkup. So dependent on how far that probe goes underneath the gum line, you can get a good idea of the patient's sort of perio or gum condition. So as you can see, there has been a clinical loss of attachment. The fibers and ligaments are damaged. There has been bone loss. So this is what we would consider to be a pocket. Causes, risk factors of perio. So we've already discussed poor hygiene or bacterial accumulation. Now, smoking is a huge risk factor for perio. There is a much higher prevalence of perio in smokers due to the invasion of pathogenic bacteria and a weakened immune response, which then in turn aggravates an inflammatory response. So it's always important to remember as well that smokers will have a less successful response to perio treatment due to their weakened immune response. Uncontrolled diabetes. Research suggests that this is a two-way street. So Perio may make it more difficult for people who have diabetes to control their blood sugar, but then Perio will also raise people's blood sugar, which will in turn result in diabetic complications. Stress. Stress increases cortisol levels, which are an anti-inflammatory. So when produced in the gingiva, it stimulates more protein production, which in turn increases inflammation and increases the rate of progression of Perio. Pregnancy, your hormones are fluctuating. They're all over the place. So your gingiva become much more sensitive to the presence of plaque and bacteria. Genetics, another big emerging factor. If gum disease runs in the family and there is a history of it there, of people losing their teeth much earlier on in life, then it probably means that you have a higher susceptibility to it as well. Systemic diseases, another emerging factor, cardiovascular disease, gastrointestinal disease, big links to Perio. Sorry, it just skips to the next one without me wanting it to. So this is the new periodontal classification. So the latest one before this was carried out in 1999 by Armitage. So the European Federation of Periodontology gathered a big group of scientists and clinicians to revise it and update it and develop this. So the most important thing to note here is that we have a category for periodontal health and gingival diseases and peri-implant diseases and conditions, which we didn't have before. So let's go over it in a little bit more detail. So for the first time ever, patients who have had active perio and are what we call in remission or stable now have a category. So those with an intact or working on a reduced periodontium are considered stable and have periodontal health. Gingivitis, funnily enough, was never given a category before this 2017 update. So there are two subcategories to this. You have a biofilm-induced gingivitis as a result of plaque, and then non-biofilm-induced gingival diseases. So developmental disorders, immune conditions, pigmentation, and many, many more, which I'm not going to list because there's too many. So periodontitis is now grouped under one category. The terms chronic and aggressive have been thrown out. They are outdated. They are no longer really used, and instead we use a staging and grading concept. So stages 1 through to 4 determine the severity. So 1 being least severe, 4 being most severe, and this is based on radiographic assessment. Grades A, B, and C will determine the susceptibility. So grade A with a slow rate of progression, B is moderate, and C is rapid. And then what stayed the same is the terms localized and generalized. So less than 30% of sites affected indicate localized, and more than 30% of sites affected indicate generalized. And associated risk factors are also included in the diagnosis, such as smoking and uncontrolled diabetes. So this is necrotizing periodontitis or necrotizing diseases, which come under a sort of branch of the periodontitis category. So as you can see, very distinct appearance, punched out gingival appearance, loss of interdental papilla, very red, very ulcerated gums, incredibly painful condition. And in terms of risk factors, stress, poor hygiene, and smoking are big ones. And it's important to note as well that this is a different type of bacteria known as fusobacteria and spirochetes. So a little bit different to your traditional perio, let's say. Treatment options, very gentle debridement, probably using local anesthetic because this is incredibly painful. If patients can't tolerate that, then probably antibiotics first to treat the initial infection. Oral hygiene instructions, lots of supportive care, and possibly some mouth rinses as well. So the third branch, or the third category, sorry, to the new classification, periodontal disease as a result of systemic diseases. So the International Statistical Classification of Diseases and Related Health Problems have a list of recognized conditions and diseases which have links to perio, which you can find them online. For example, papillon-Lefebvre syndrome, a rare disorder that will often result in the early presentation of severe perio. Now, systemic conditions which will affect the underlying structures but aren't as a result of plaque or bacteria will come under the other branch known as the systemic diseases and conditions affecting the periodontal supporting tissues. Fourth and final category, peri-implant diseases. So with implants on the rise, people are choosing to go or sort of stay away from the less traditional more traditional options such as bridges and dentures, and are going for something a little bit more permanent and modern. So the European Federation decided to come up with this category. So implants are still susceptible to disease and bony destruction. So we have some subcategories. Implant health, implant mucositis, so which can be likened to gingivitis, peri-implantitis, which can be likened to periodontal disease, and soft and hard tissue deficiencies as well. Moving on, it keeps moving on without me. So this is just a summary of the new classification with all the subcategories, which I'm not going to go through because that's a lot of words and I simply don't have time, but you can find this online on the EFP webpage. Moving on, implementing diagnosing into practice. So you cannot pick up a probe, you must pick up a probe in order to diagnose perio. You cannot simply look at a patient and do it by clinical examination. So it must be diagnosed via a BPE. Well, your BPE is your screening tool. So further periodontal indices to confirm and a radiographic assessment. So dentists make sure that you have appropriate radiographs and which are taken at regular intervals and of an appropriate diagnostic nature. So what I mean by that, crestal bone levels have to be visible in order to diagnose periodontal status. Hygienists, therapists, if you are trained and competent to do so, and it is clinically justified, take them yourself. Make sure a dentist reports on them. The type of radiographs that you need, so gold standard according to the BSP would be a full mouth of PAs. However, in general practice, that can be hard because time restraints simply don't allow. Bite wings supplemented with appropriate periapicals will usually suffice as long as the bone levels are visible. And for more complex cases, OPGs might be necessary, supplemented with PAs. So how to diagnose perio? So this is the staging and grading concept I was speaking about earlier. So first of all, take your radiographs and use the look for the bone loss and check the worst site of bone loss on your radiographs and use this to determine your stage. In order to determine the susceptibility, this is your grading. Take the percentage of bone loss, a rough estimate, let's say 50% of the worst affected site, and divide it by the patient's age. And this will give you a figure which will determine the rate of progression. So if a patient is pretty young and they have had 60% or 50% bone loss, you can assume that the rate of progression is fairly rapid. Now, the current status will be determined by probing depths and bleeding on probing, whether it's present or not. And then you also include your risk factors such as smoking and uncontrolled diabetes. Next one, perio is risky business. So almost 2,000 claims between 2013 and 17, and almost 45% of them were perio. So as you can see, perio litigation is huge. 75% of this is due to simply failing to diagnose. So make sure that you diagnose and inform your patients of your diagnosis. Make sure that your notes are bulletproof. Record your discussions, record your findings. Remember that a good set of notes equals a good defense if it were to ever come to that. Inform your patient, get a treatment plan, gain consent for it, provide the appropriate care and review them in a timely manner. And if anything, at your reassessment stage, discuss further treatment or a referral if needs be. So treating perio in practice, I am guilty of this at the very beginning. So I would say my top tip, do not stress yourself about trying to get everything done in one visit. Perio is not about just getting the job done. It is lifelong management. It is not like excavating caries and carrying out a filling and Bob's your uncle. It is much more than that. It is implementing behavioral changes, lifestyle changes, patient education, motivation. It is about forming long-standing habits, and it is a lifelong, it's lifelong management, as I said earlier. So do not stress. Treating perio in practice. So this is the sort of general care pathway that I have found works for me. So I get a new patient, check the BPE. If I score a code 4, I'll check the radiographs. Perio present, I'll inform the patient. I'll give them their options and obtain any valid consent if they decide to go ahead with treatment. Important to remember, patients are not obliged to go ahead with treatment, so they have the right to say no. And I have come across a few like this. So make sure that you document everything, all your discussions, all your findings. For argument's sake, they've said yes. Periodontal assessment, I do my treatment plan, I plan my appointments with appropriate intervals. do my gross scale if I have time at the appointment, and most importantly, start with my oral hygiene instructions. And I have to reiterate to the patient that home care is essential in trying to stabilize perio. It is 30% what I do and 70% what the patient does. I will then do my non-surgical therapy, otherwise known as root surface debridement, sometimes using local, sometimes not. Now, the reassessment, I know everybody gets taught differently. So I was taught between 8 to 12 weeks for your reassessment. I know specialists that leave it 6 months before the assessment. So it depends what evidence and what guidance you want to use. Roughly, I do 8 to 12 weeks. When to refer after you've done your reassessment, and for example, you need to refer. So these are just a few examples. Patients with really severe, presenting with initially really severe disease and look like they be a complex case, offer immediate referral. Patients who want to go specialist treatment straight away, so you inform them of their diagnosis and they want to see specialist. Non-responding pockets following non-surgical therapy. So if a patient comes back with residual pocketing, which is still bleeding and unstable, I will then either retreat or offer a referral. Again, patients are not obliged, and a lot of them turn down referral because A, they are not in pain, and B, they don't understand the importance of it. So an analogy that I like to use sometimes is if you go to the GP with a heart problem, you will say to the GP, I have a heart problem. The GP will know roughly what to do, but if they feel that they need further guidance or you would be best placed in the care of a specialist, they will send you to a cardiologist. So it is exactly the same situation for your gums, okay? Non-plaque induced periodontal disease, so something that might be out of your experience or out of your scope of practice. Peri-implantitis, gum disease around an implant, furcation defects, abnormal root form morphology, which would make non-surgical therapy hard. Patients with compromised medical histories or with special needs and may require a multidisciplinary approach. So they simply might not be suitable for general practice and general treatment. Who to refer to? So it's important to distinguish dentists with a special interest in and what a specialist is. So the dentists with a special interest in have a job title and have had some extra training following after BDS level. However, a specialist has been officially recognized by the GDC by having undertaken postgraduate training in the discipline of periodontics. So they have gone the extra mile in studying perio and gums, let's say. Okay, now the scope of practice of a periodontist. So they are able to do non-surgical therapy just as well as a hygienist or therapist or dentist is able to. Surgical therapy, so this is what comes out of a hygienist or therapist remit. Flap surgery, essentially. So we open up the flap, or they open up the flap, they clean out the root surface of the gum, all the disease-causing bacteria, and then stitch the gum back up to eliminate that pocket. So that is one option. Providing antimicrobial therapy, antibiotics where indicated, gum grafting surgery to treat severe recession, laser treatment, although there is insufficient evidence to show that it is very useful in treating perio. Regenerative procedures such as bone augmentation. So if a patient has had severe bone loss in an area or has got a vertical bony defect, then this would be quite useful for them if indicated and if, you know, the patient is suitable for it, basically. But that is an option. Crown lengthening and implant disease. So that takes me to the end of my slideshow, and I hope you have managed to take something from this. I hope you've enjoyed it, and I hope that makes you feel a little bit more confident in regards to perio and treating perio in practice.
Thank you, Maya, again for joining us and for that great presentation. Before we move on, we wanted to thank once again to Septodon UK for sponsoring this event. At the moment, we are working with them to continue to provide the best resource for you and other dental students and professionals around the world. And this collaboration will allow us to offer new immersive content real soon, but also competitions like the one that we are hosting at the moment. If you don't know what I'm talking about, please visit our Instagram page at Immersify_ed and look for our giveaway post. Amazing prizes are waiting for 5 lucky winners, so make sure you enter this competition. It's super easy, you'll see. Anyway, that was the end of our more academic side of things. We are now moving on to discuss other things related to dentistry and this beautiful yet difficult journey you are on at the moment. For that, we now have Robert Leigh joining us. He is recently qualified dental hygienist and therapist. And Robert has written articles for BDA, and he has actually been part of the Immersify team since pretty much the beginning. So we're super proud of his journey and the fact that he is a qualified professional now, and we know that it wasn't easy. So Robert will be talking about what it's like to qualify during a global pandemic. So yes, I'll leave you guys with Robert, and I hope you enjoy his presentation.
So I'm here today to talk to you about my experiences of qualifying during a global pandemic. So my name is Robert Leigh, and I'm a dual qualified dental hygienist and therapist, and I qualified from Eastman through the Royal College of Surgeons, and I'm also an Immersify dental innovator. So my experiences of dentistry. So I worked as a dental nurse after my A-levels. I did that for a year. That gave me my first sort of insight into the dental field, and it was a tough job. And I graduated this year from Eastman Dental Hospital after studying hygiene and therapy there. And I've just started working in May, so it was just a couple of weeks ago. And I currently work in the practice that I used to be a dental nurse at, which is a mixed den plan and NHS private practice. So I see purely the private and the insurance patients there for their hygiene treatments. And the question that probably from March of last year until probably March of this year, but the worst time was between that March and August time last year was, will we ever qualify? And I think the phrase that we used quite a lot with our tutors was, will we ever escape? Like, are we ever going to get out of here? And especially with any delays that you face. So we were delayed by 3 months. The group below us, because exams were completely cancelled, they were delayed by 6 months. And these delays can be extremely frustrating, and they are massively disheartening. You feel as though all your work is just being put on hold. You've at some points, and you would have felt it, you feel like you're just sitting in this bottomless pit of getting nowhere. But these delays are for a reason. They're not just to spite you. They're not just to make you stay for longer. They're not to delay you really getting out there and working and earning money. The theory is important, and whether you've spent the last year revising solidly or you've really struggled to do any studying, the theory is important. Anyone can sit there and read a book and learn what's in the book and learn the theory, learn all of that. But the clinical skill needs to match this, and because your job will be, the clinical skill is backed up by your theoretical knowledge, you need your clinical skill to be at the level where you feel confident with it. And I think looking back, in December, when I should have qualified, my skill was nowhere near where it was, and I didn't feel as a person I was as confident as I was when I left in March. So that delay and that extension to the training was worth it in the end. It put me in a lot better place. And it's giving you more time to perfect your skills with direct supervision. There's not many opportunities in your life. Obviously, if you go on and do a course, you go on and do VT training or something, you've got that indirect supervision, but there's not many chances in your life aside from undergraduate study where you've got someone leering over you, watching your every single move. And that can be off-putting, as we all know, but you relish not having that when you finish, but you do miss it to some extent as well. And that extra time under supervision is invaluable. As I've said, you will miss it when you graduate. Yes, you're not completely on your own. You're not sort of chucked out there with no one to support you, but you definitely do miss having that direct support there. So some of the positive things that I found about graduating during COVID were, there's definitely an element of increased resilience. If a dental course hadn't made me resilient before, definitely during COVID it massively increased that. If you can get through any degree or any study, you can get through anything, but if you can get through it while you're working during COVID, while practitioners who have been qualified for years actually in the real world have been scared, have found it extremely stressful, it's fair that you have as well as a student, and that we all have as students and newly qualified. So if you can come out the other side of that, which you will do, it seems like a never-ending tunnel, but you will get out the other side. You can do anything. And when you do finish, you're better prepared for the real world. You've not worked pre-COVID for your whole time of undergraduate studies, as some of the students unfortunately were in the situation with last year, and then been chucked into the real world, and your first experience of an AGP is in practice on a real patient. Now that we're still studying, or you're just about to qualify, you've got that advantage that you've practiced as a student during COVID. You're aware of the limitations, you're aware of the impact on patient care, the impact on ourselves, on our own bodies, on our own state of mind, and you can try and use that newfound knowledge to actually be an asset. Tying in with that, you're also used to carrying out AGP, non-AGP treatment. You come to learn what can be done under a non-AGP setting, and perhaps that you don't need to just pick up the ultrasonic as much as we would all love to, or just pick up the high speed. You have to plan your treatment a little bit more. So you're planning, as opposed to doing treatment by tooth, you're having to do it perio, say by a half mouth instead of a quadrant if you're using the ultrasonic. Restorations, obviously you're planning to try and do it by either half mouth or quadrant, or whatever the patient sort of needs indicate, but you're having to try and in the real world reduce the appointments, especially if a patient is having a sort of treatment where they're paying by appointment. They can't be coming in for 10 different appointments, and also you can't be completely removing the financial impact that is in the real world. And having worked under this AGP situation where you're having more strict appointments, you're having to consider things like fallow time, you're having to consider how many appointments the patient's having. Does that one need to be AGP? Does it need to be non-AGP? Your treatment planning skills under pressure will be massively improved. However, there are also some sort of cons, some negatives that I've felt graduating during COVID. One of the main ones being that you feel that you've not had enough clinical experience. I don't think at undergraduate, whether you do 100 of one procedure, 10 of one procedure, or 1,000 of one procedure, or you do it just once, you're never going to feel that you've had enough experience in that procedure, whatever the situation. But you need to sort of always bear in mind, they told us all the time, like, you're not going to be able to qualify unless you meet your clinical requirements. We're not going to put you in the real world having not met your requirements. So don't be stressing that, oh, I'm going to qualify having done, say, a certain amount of root canals, or, oh, I've only done a certain amount of non-surgical perio, or, oh, I've only done a certain amount of class 4 restorations. You'll meet the requirements you need to be not an expert. You're not going to be an Instagram perfect dentist, but to be a safe beginner, and have some sort of trust in your supervisors. Have faith that this is their job. This is either their part-time job or their full-time job. They're not just one person on their own. They are a team, and they are working within a massive group. They all talk to each other at all the different schools. They all have meetings. They're all trying to line up. So don't compare necessarily your experience in London to someone's experience in Newcastle, say. And actually, as a group, we managed to surpass the clinical experience of previous years. So by Christmas time, we'd actually exceeded it. So having that extra 3 months gave us the ability to really perfect our experience, so it is possible. And another point is, when you come into the real world, there are some challenges, like always, about finding work. There is work out there. Certain areas of the country are maybe slightly more challenging. There's less work, there's more work, there's more private work, there's more NHS work, there's less places on a VT scheme, but it may mean that you're waiting a little bit longer for the right opportunity. Don't be disheartened if you're not getting a job straight away overnight. You're not going to be qualifying one day, working the next. You've got time for your GDC registration to come through. You've got time to sort your insurance out. Don't be put down if you feel that you're not working immediately. You're just waiting for the right opportunity to come along. And then finally, talking about exams, or second from final, but exams, they may be online. This can seem pretty stressful, especially if when we were training, all of our exams that we'd ever done were on paper. we'd sit there and we'd write, our exams were essay based, we'd write essay exams. Doing finals online was pretty stressful, but from my experience, you end up writing a lot more on the computer than you would by hand. If you've got more than one exam in a day, like your hands are going to ache, but nowhere near as much as they would if you were sitting there handwriting everything. It's a lot better. And if you've not had, I'm sure we've already done mocks online, like we did mocks online before finals. We got used to writing typing on the computer. But if you've not had a practice run, try and have that, get yourself into the swing of how much you can type. Can I type this amount in that time? Can I put together my sentences while typing? Because I found that handwriting, I think about the words a lot more, typing was a bit more challenging. I'm not forming the letters, so that's something to consider. And the exam itself, remembering that you are there to be tested. There will be things that will come up that you're not completely sure of, but the main thing is we're being checked that we're safe beginners, and remembering that common things do occur commonly, and to relate every single experience, whether it's a scenario question, whether it's just a pure knowledge-based question, back to clinical experience. Oh, have I ever seen a patient with XYZ? How did I manage that? What complications did I encounter? And that gets your brain ticking over and keeps you thinking about, that's how I managed that patient. Maybe this is, and you can sort of come to the answer a lot better. And as I've just said, the exams are to check that you're safe and that you're going to do the right thing by the patient. You're not going to treat the wrong tooth. You're not going to extract the wrong tooth. You're not going to give an inappropriate treatment for that patient, but you're not expected to be perfect. You're not expected that when you graduate, you're going to work in the real world at consultant level or dentist or hygienist that's been qualified for years level without anyone else's input. You're not going to be perfect. And even 10 years down the line, none of us are going to be perfect. So going into the real world, firstly, you will be extremely busy, I'm sure. So my diary at the moment is full every day. I agreed to start working. My diary was opened and the first month was full within about 2 days. And that's working sort of 16 hours a week at the start and then 25 now. You will be busy and you will have a waiting list. My patients are rebooking in again in 3, 6 months, a year's time. So those slots are already going. So then newer patients to seeing me that haven't seen me before, the diary gets full up. Expect patients to have some heavy build-up. You may be surprised, but from the patients I've seen, there's a fair amount of build-up. They've not been for a while, and lots of staining as well. Factoring in AGP appointments, justifying that AGP, and perfecting your skill of hand removal. And be aware of lots of mucarious lesions. Some patients haven't been for 18 months. Probably by the time you qualify, have not been there for nearly 2 years. If they were due a checkup in March, it got cancelled. They may have been in August of 2019. It will be 2 years since they've been. Be aware of these carious lesions. Spot anything that's there and flag anything that's suspect. Tying in with that, I've not written it down, but oral cancer. Make sure that your oral cancer screening is happening. Really, if you have any questions, don't sit there and boil over it. Go and ask someone. Even though we're newly qualified, don't be afraid to ask for support. Obviously, you're not going into the practice manager, the boss, and going in every day with a question, or into another dentist or an associate or a hygienist going, question all the time. But if you're stuck, just like you'd ask a friend or ask a tutor on clinic, ask someone else who works there. You're not working there on your own, you're part of a team. And if you're working with a dental nurse, actually sometimes ask them about a piece of equipment. Ask them about how other people would manage a patient. Yes, they may not have the same clinical training as you, but a lot of them will have a few more years of experience than we all do, which is invaluable. So finally, I just wanted to say thank you to everyone for listening to me. And if you've got any questions, then feel free to contact me. I'm quite easy to find, or you can contact Immersify and they'll pass your questions on to me. And there's a picture of me after one of the wonderful AGPs. So hopefully we won't all be wearing those lovely masks that bruise our faces for much longer. And thank you again for listening.
Thank you, Robert, for sharing your experience of qualifying during COVID-19. I really hope you don't have to wear that mask for any time, like anymore. It just looks like a nightmare. Before we move to our final speaker, I just wanted to quickly thank SAMHSA. For those who don't know what this is a student-run society which is dedicated to supporting sixth form students in local state schools as they take their first steps towards a career in medicine or dentistry. They do a really, really amazing job helping highly motivated students who have the academic potential to achieve the grades for medical and dental school. So if you guys know anyone who is in that journey, please reach out to SAMHSA and I'm sure they'll be able to help you. Having said that, finally, we want to welcome Dr. Mahrukh Khwaja. For those who don't know her, she is the founder and CEO of Mind Ninja, and this is a well-being startup that provides resilience and mental health training to dental and healthcare professionals in general. And we wanted to close our event with her because she has helped so many dental students, dentists, throughout the years that we thought that it would be like a perfect way to conclude our presentation. Dr. Mahrukh was actually named in the top 15 dentistry in 2021 by FMC for her work on mental health in dentistry. And the topic for her presentation today is mind fitness, building student resilience, and the importance of well-being. So without further ado, here is Dr. Mahrukh Khwaja. Hope you guys enjoy our final presentation.
Hi, welcome to my webinar on mind fitness, building student resilience. I'm really grateful for your time. Today we're going to delve into psychological tools that can really help emotions and combat common negative thoughts. Just before we kind of delve into these tools, I want to talk a little bit about me and we'll talk about a really incredible, very important, relevant topic. My name is Dr. Mahrukh Khwaja. I'm a dentist of 11 years and I've always done. In fact, I am duly qualified with a psychology degree and have just recently completed a master's in applied positive psychology, which makes me a positive psychologist. I'm also very much interested in mindfulness and excited to have got my teacher training a few years ago. Also a couple of years ago, I founded Mind Ninja, a well-being startup that really helps dental professionals live happier, healthier lives through learning more about the mind. I specialise in resilience and have always had a very keen interest in helping dental students. In fact, last year I was involved in the pilot resilience training programme for King's fifth year dental students, and I've done lots of workshops with dental students over the years now. Now, as a student, things were really quite different for me, and I'd say I was quite a different person in my thoughts and kind of my beliefs around the world. I was certainly very scared about picking up a drill. I was worried about breaking a tooth constantly and feeling really like I wasn't good enough to be at dental school. Constant kind of social comparison and an avid procrastinator, really anxious around exams and really overwhelmed with the amount that we needed to learn. And this led to low levels of self-esteem, low levels of resilience and happiness, but also high anxiety, high perfectionistic kind of thoughts. And ultimately, this really influenced my mental health as well and led to things like burnout, compassion fatigue and depression. So all of these aspects I'm talking about really impact us and are actually occupational hazards for dental professionals. So, you know, no matter where you are on the mental health continuum, you may never have experienced any issues, but certainly just being within dentistry means that we're more likely to come across these conditions and we're more likely or more prone to having things like burnout. So it's really important that we address these things early and really build those tools so we can really help ourselves before we get to that point. Now let's delve into the mental health of dental students specifically. Now we know that burnout actually often starts at undergraduate level, and burnout means a severe state of emotional exhaustion. And there's also an element of where we don't feel like we're making a difference, so we're not getting that sense of personal accomplishment, and we also lose our sense of empathy, which is really important when we think about connecting with our patients and actually doing good quality dentistry as well. We know that there's several reasons for this, and you're going to be aware of this as a dental student, but high stressors certainly make a big difference. Clinical pressures, quotas, exams, all of that aspect, and of course social media, social comparisons. A recent study by Colin and colleagues in 2020 explored perfectionism and found really high levels of perfectionism and this impact on mental health, and this connection between perfectionism and kind of negative coping strategies, higher psychological distress, high levels of burnout. So, an obvious kind of an issue when we're thinking about the mental health of students. Now, how can positive psychology really help dental students? And this is, really the basis of what I'm teaching here. So you have traditional psychology that really focuses on weaknesses, illness, healing, repair, and it's very much that kind of disease model. Positive psychology is a branch of psychology, and it's focused on why individuals and organizations, thrive and flourish, and what kind of attributes they have, what strengths they're using. It really focuses on well-being as well. So we're really talking about positive well-being markers and how to boost those as opposed to reducing the negative well-being markers as much. It's a much more focus on things like, so if we look at the topics, things like emotional intelligence, happiness, quality of life, resilience, optimism, mindset, self-compassion, mindfulness, all of these things that are really relevant when we're talking about well-being. So, really exciting, important research that's coming out and really kind of relevant when we're talking about building our sense of well-being. Now, I want to delve into 3 common, unhelpful, but very natural thoughts today. So I'm going to start off with, I'm not good enough. This is going to be a really common negative thought that you may have kind of come across already. So this thought is where, we really feel like we're in this position as a dental student, perhaps we shouldn't be there, and I certainly did as a dental student. We might be comparing ourselves with other people, feeling as though we're not we're not going to be able to, and for fraud, you're going to feel like you might get caught out and found out that you shouldn't be there. So all of these thoughts are actually quite common. We know that in dentistry, when we look at the research, that a lot of us have type A personality traits, and that lends itself to things like this, but it means that we set very high standards, and perfectionism is aspect of perfectionism. If we delve into that, ultimately it means that we are setting these very unrealistic high standards, and if we don't meet those standards, we feel very upset, and we feel like it's a reflection of ourselves. What's driving perfectionism is a highly critical inner voice, and a very much focus on results and a fear of failure. So you've got all of these elements kind of playing into this. We know that procrastination and perfectionism are very much linked as well. And there's a similar kind of driver in this fear of failure. And so we put off doing things that are important because we are really bogged down with this negative thought. And so we do anything to get away from that thought. Now, when we look at the fitness menu options for perfectionism and procrastination, we can choose several different things. Really, it's about finding a mind strategy that works for you, because there isn't a one-size-fits-all kind of approach to this. So it might be mindfulness that works for you. It could be acceptance, self-compassion, or reframing. So those are the different kind of tools we can use. And I wanted to kind of delve into what that means. So if we look at perfectionism or imposter syndrome, this sense of really this highly inner critic and a sense of, I'm not good enough. In terms of mindfulness, we might want to pay attention to the thoughts and feelings in a non-judgmental way. We might think of thoughts as clouds, that they kind of come and go. And this immediately puts some distance between ourselves and those thoughts, and we're reminded we're not our thoughts, and you can get a lot of comfort in that. So mindfulness can be a really great strategy for just being an observer, as opposed to kind of feeling that need to constantly connect or engage with those thoughts. You're ultimately not buying into what those thoughts are saying. Now, another strategy which is really useful comes from acceptance commitment therapy. And this is where we let our emotions run their course and use, humour to really dissipate those negative emotions. So we might say to ourselves, oh, hello, perfectionism, you come and go, there you go again. You might have a funny name for those common thoughts. And it just immediately helps to kind of diffuse the situation. So you can use humour or tricks like that to create some distance and just remind yourself that this is kind of a common and natural thought, and it will go itself. Self-compassion is also another really interesting tool that we can use here. And self-compassion ultimately means offering yourself kindness in moments of stress and suffering. And it's being, how you would be with a good friend. So really thinking about, what would you say to a friend who thought this, and how can I use the same kind of words of kindness to myself at this point? And you might want to soothe yourself with a physical touch as well. So it might be that you squeeze your arm or squeeze your hand. And you want to remind yourself that these are common thoughts, that you're not alone, you're not isolated in this journey. So that can be really, really helpful. Another element to this is reframing. So you might want to ask yourself, what's the evidence for and against this thought? Is this belief helpful? And immediately that can help. When it comes to anxiety, and this could be a common kind of negative thought for you, whenever you pick up a drill or start a new root canal or the difficult procedure, as a dental student, we're learning so many things. We might want to think about strategies for that. So again, you can use mindfulness, acceptance, self-compassion in a similar way that we just described. It also might mean exposure. So what that means is experimenting with doing this procedure and thinking, look, I feel this fear and I'm going to do it anyway. And if it's difficult to do in one go, build up in smaller steps. So think about your root canal and think about doing certain steps in that root canal as opposed to too much in one go, and that can help with just making things a bit more manageable for you. You might want to talk as well with your colleagues and just notice your feelings and talk to another person. That can be really, really helpful. Third aspect or negative thought is when we are really feeling immensely overwhelmed, that we're not going to be able get this done, that we're going to fail, and it's a very uncomfortable negative thought. And again, we can use those things like mindfulness, acceptance, self-compassion, and talking. And there are some other elements that we can use in terms of mind tools, and even physical exercise. So with physical exercise, we know it really does impact our brain health, and can really help us when it comes to building resilience and well-being. So 30 minutes 3 times a week of aerobic strength building exercise. I think the key with this is just finding something you enjoy. So it could be things like trampolining, it could be running with your favorite podcast. So thinking of ways you can kind of embed this. Another aspect or tool that can be really helpful is problem solving. So brainstorming all possible solutions and writing these down, evaluating the pros and cons for each option and giving each option a score out of 10, and then choosing an option and doing it and reviewing it. And that can be really helpful because you're really breaking down this problem that you have and making it very rational, very clear about the steps and what you're going to do, and you're planning really. So that can be really helpful when it comes to alleviating those feelings of overwhelm. Great, I hope you enjoyed this short webinar. You can connect with me on myninja.ltd, my website, myninja.org, or email me on myninja4dentist@gmail.com. Thank you so much.
Thank you, Dr. Mahrukh, for the advice to all listeners here today. Please do follow her on social media, reach out to her if you need anything. She's really supportive, and I'm sure she will be able to help you if you need it. That brings today's event to a close. We know it's been very, very busy time for you guys with exams at the moment. So you will be able to access these presentations at any time. If you know anyone in your network who couldn't tune in today, we will be sharing the link to this event in our link in bio on Instagram. So please share this information with them and let them know that they will be able to access these talks from today. Before you guys sign off, just two really quick things. First one, we are really happy to announce that we will be launching a new feature on the Immersify Dental app next week. We will be having 3 new sets of MCQs on different topics. So please make sure to update the app as soon as they're out. We will be sharing more information on this on social media, but just please check regularly on the App Store and Google Play for any notification. And the second one, just a quick reminder, if you have any questions, please go on our Instagram story and leave it out on the question box, and we'll get back to you as soon as possible. The entire Immersify education team, we'd like to thank you all again for joining us today. Once again, thank you so much to all our speakers. Amazing job. Thank you so much also to Septidon for sponsoring this event, and obviously you guys for tuning in. Have a lovely weekend, everyone, and we hope to see you again all soon for our next event. Take care. Bye.